Okay, good evening. We would like to get started on this last segment of the evening, which is the fireside chat. As you can see, there is a fire, and now there will be some chat. So we are going to talk about some of the topics and the literature review about some of the interventions and some of the interactions between public health and shelters. And my name is Yoav Keynan. I'm the scientific director of NCCID, and with me there are three guests. I'll start by the order of sitting. Tessa Blaikie Whitecloud, who is from Siloam Mission. Welcome. Sandra Allison, who is from Island Health, BC. Welcome, Sandra. And Maureen Dobbins, who is the Scientific Director of the National Collaborating Center for Methods and Tools, NCCMT. So we'll start by reviewing a bit of the literature, and I will turn the microphone to Maureen to tell us a bit about the synthesis of information in the literature about the interaction of public health and different approaches that could be taken that the NCCMT has conducted, and you have received it in your packages, so you can scroll through it if you haven't had a chance. But the idea is to try to summarize some of the findings and use that to spark our conversation here. Maureen.
Thank you, Yoav, and thank you for the opportunity to be here. If anyone has any feedback on that very academic-looking report, I'd love to hear it as well. So my center actually did a right-hand turn during COVID and started doing many rapid reviews to support COVID decisions or public health decisions around COVID. So it's not something that we normally do, although we have a lot of experience in that realm, but we were mostly supporting others to learn the skills, how to do reviews. And so we were delighted to have a conversation with Margaret probably about this time last year around the Winter Institute that would be happening about now. And was there something that NCCMT could do to support this? And so what's natural for us is to look in the literature, and that's what we offered to do. We're not experts in shelters and in the issues that people who work in shelters deal with. So I had a really lovely afternoon, incredible conversation that I feel privileged to have been a part of. From I guess one of the first things to say about the review is it's what we would call a rapid scoping review, which was completed fairly quickly, not to answer questions around what works with partnerships between public health and shelters, so no questions around the effectiveness or the impact, but rather the scoping review was to describe what exists in the literature, because to be really honest, we really did not know what would be in the literature. And we were surprised at how much was there. We thought we would actually find a lot less than what was there. So just a little bit more overall, if you take a look at it, what you might note is there's not a lot of Canadian studies that have been written up and put into the published literature. We also looked for gray literature, so unpublished reports, although I don't believe we found any. So we believe there's, and as this afternoon showed, there's an incredible amount of knowledge that exists that isn't being written down, and we need to figure out how to tap into that. But overall, in a nutshell, there were 11 syntheses, which was really encouraging. So syntheses are a topic, and we go and look for all of the studies related to that topic, and we put them all together and try to make sense of them. So there were 11 of those, and then 41 other studies, single studies that we found. And this was all literature that was available up to about the late summer of this past summer. And there were studies that described models, we called them models of care, that were describing different kinds of partnerships between public health and folks that work in shelters, and sometimes even other multi-sector partnerships as well. And then there were a variety of studies that were very topic specific. So the one most prevalent was dental care being provided through shelters. COVID-19 was next, then sexually transmitted and bloodborne infection studies, TB and other infectious diseases. About 5 studies on mental health and substance use, and then a couple on more broadly health promotion. And it covered quite a range of different types of public health services, so prevention, screening, some of the usual things we hear about in public health: screening, testing, health promotion and education, harm reduction, infection prevention and control, outbreak management, immunization, treatment. One of the things that we noted, and we've noted this across all of the 80 rapid reviews that we've done, almost all of them, we've seen this in the literature, is a lack of reporting on specific populations, whether that's Indigenous populations, other equity-deserving populations. So even in this evidence, in this body of literature, which is about shelters and services offered through shelters, even within that, there's very limited studies on specific populations that we could learn from. So from a funding perspective, I think this talks a lot to what's being promoted as calls for funding, what types of studies are being funded. Our funders, I think, need to get better in terms of some of the priorities. And then I'll just wrap up with one more area, which is just around what kinds of relationships or partnerships were being discussed. So sometimes they were talking about collaboration between organizations, as I said, so it might have been public health and a shelter or other organizations, but also it looked like when the experiences of those using the shelter and those experiencing homelessness were driving the partnership and the development of addressing the needs of that population, that did appear to have longer standing partnerships and more sustainability than when it was something that was being driven, let's say, by the public health unit. And you alluded to that today about who's not in the room with this. I think we only saw 1 or 2 studies that really had this very broad multi-organization involvement in a partnership, including community health centers, housing and social services, Indigenous advisory groups, hospital sector, academic institutions. Only 1, maybe 2 studies looked at that. And then I think I'll probably just stop there, leave a few things for a few other questions.
Thank you very much, Maureen, and thanks for this review that sets the stage really on identifying some of the areas that are studies, but also the vast gaps that there are. Were there any surprises, the main surprises for you in this review? What was missed or what was glaring at you?
So as I said, we were pleasantly surprised that there actually were 11 syntheses and additional studies, single studies to look at. So as I said, when we first met with Margaret and started talking about this idea, and we thought, I don't think there's going to be much there. We'll be probably done this really quickly. So we were really pleasantly surprised that there is a body of literature there. However, it is concerning how little of it is Canadian, And that's something I think we need, that's a call to action around making sure that folks that are funding research that ends up in the published literature, that we're calling on them to make sure that research is done in this area. I was a bit surprised looking at it that there's gaps in the timeline. So we have some recent syntheses. So in certain areas, one's been done like in 2022, a couple in 2020, 2019, and then we have this big jump to more than 10 years ago before there was another one, and much of the single literature is like that too. So it seemed like there was more going on around late, like 2008, 2009, 2010, and then things seemed to fall off up until more recently. So that was a bit surprising for us. There's a lot more focus, we think, that needs to be put on describing partnerships and what does that mean. We took a very liberal definition of that word in that anything that suggested or described people working together, we decided to include that. Because at the end of the day, while I'm saying there is a good amount of literature, it's still pretty small. So we were very liberal, but that doesn't necessarily say anything about the quality of the partnerships or how formal those partnerships were. And so we think there's still a great deal to be unpacked about what makes partnerships impactful and sustainable. And
while you're looking, one of the things that I think is super interesting about that timeline is that lines up with the recession. And homelessness is sort of this thing that only gets on our radar when people get annoyed with it. And people only really get annoyed with it when there's more people than the shelters can handle. And there's only really more people than the shelters can handle when there's economic crises or economic policies that throw people into crises. And so I think it's interesting to think about the recession as this, all of a sudden there's all of this research. Coming out of the pandemic, all of a sudden there's all of this research. The end of CERB has led to a gross amount of homelessness because it was sort of functioning like a UBI, a universal basic income. And so I think it's interesting, like as soon as, I was like, she's gonna say 2008, and then you did. And I haven't looked at that research. That was not my area of research in my own studies. But yeah, so homelessness sort of, we are reactive to it. And what I hope in your call to action for people to do this research is that we can start to be proactive because we know those solutions and they're much more effective and way cheaper.
Thanks. Anything else to add? So I'll turn then to Tessa with the next question.
Sorry, I cut in line a little.
No, that's it's a chat, so you. So Tessa, a lot is missing from the journal articles. Lots of information, and as Maureen alluded to, a lot of knowledge is not kept or not translated to papers. What are some of the things that those papers showed that you agree or see in your day-to-day life in Siloam Mission, and what are the main things that are missing from those papers?
Yeah, so I'll just say all the public health topics covered like totally align with what we see as some of the concerns and issues at Siloam. There's 3 others that didn't make it into this that I think are of interest that I'll talk about in a second. But one of the things that we see a ton of is people who've used their entire dental allotment under EIA, but have something really severe that if left untreated would lead to more issues. And I think in your review, you were looking really at people experiencing houselessness, but there's a lot of folks experiencing unstable housing or who are actually housed, but a dental bill would just break the bank. So a lot of our work at Siloam is actually on housing loss prevention, and it's interesting because we often don't think about some of the medical care that we're providing with unpaid volunteer dentists who are just giving their time. to people as housing loss prevention, but it is actually that they wouldn't be able to afford that and maintain their housing. We're so blessed to have a wonderful relationship with public health. Like, they come in weekly, we've got STBDI testing, we've got inoculations, they're here for us. We can reach out to lots of folks within public health for support, and certainly did during the pandemic. But a couple things from the research that I noticed are missing in terms of our experience. One is the prevalence of acquired brain injuries among the population of people experiencing homelessness. And all of this research comes from the States. But in the States, they say about 50% of the adult population experiencing homelessness has an acquired brain injury. And for 70% of those people, that brain injury happened within the 9 months before they started to experience homelessness. So from a public health and a primary care perspective, we can really see homelessness as a symptom of acquired brain injury and a lack of care after acquired brain injury. The other thing that I think for us is a really big public health need in Manitoba is that, so this week at Siloam, we called an ambulance 5 times for an overdose. Since Sunday. Last year, we administered over 100 doses of naloxone. And so the lack of those resources around safe consumption means that places that are not trained or funded to be safe consumption sites are acting as such. So we don't want to be, because we'd rather that there was one with nurses and nurse practitioners and more care and drug testing. But by accident, we operate as a safe consumption site. And knowing what to do and how to respond to that, and also knowing the long-term effects, because, you know, if the same person, and we know them and we love them, so we witness it, that it's the same person. Last time he took 3 doses, this time it took 7, right? What's it gonna take next time? Is it even safe to give that much? So there's those types of questions that I think really struggle. But I think the thing that I actually thought would really be in this research was foot care. Because when you're experiencing homelessness, your feet are your house and your car. And so many people experiencing homelessness are experiencing also unhealthy diet as a result of that financial burden. And also, we make sure that there is a vegetable on every single plate at Siloam. And that's where we spend all of our money, because none of that gets donated as often as we'd like. Not none of it. Second Harvest is great. We've got lots of amazing partners that donate it. But it's a challenge when you're doing, thousands and thousands of meals a day. And so people are also experiencing more diabetes when they're experiencing houselessness. And we know, because we did a pitch, this was at a previous place I worked, also in the sector, we did a pitch for funding a foot care program. And we could serve 28 individuals a month and probably really change their dignity and their care. And if we saved 1 amputation at that time, so this is a 2015 dollar amount, that would have been $180,000 in the system at that time. Funding that program would be around 50 grand. But we didn't get the funding. So again, volunteer foot care nurses, volunteer foot care practitioners, podiatrists, all of those people come in and give their time, which right now equates to 8 to 12 hours a week. But if we had someone full-time doing foot care, what is the dignity that we could preserve? What is the comfort that we could preserve? What capacity would we offer somebody to transform? And so I think it's from a public health perspective, what is the prevention? And earlier today they were talking about having wartime illnesses. We had a trench foot outbreak. That's ridiculous. And could we got ahead of it if we had that type of preventative approach? So those were the ones that I was interesting that it's not there.
Thank you very much, Tessa. I'll turn to Sandra and ask you what aspects of public health you think need to be considered when we're discussing in the settings where public health resources are overwhelmed, when the needs of the community are multiple. How do you balance those?
Thank you, Yoav. And thanks for that, Tessa. Very interesting share. So, public health, we think about, and I've heard it, we're thinking about public health nurses, and we think about environmental health officers, and certainly they are part of the public health team. But one of our most important tools in public health is policy, right? And so we do need to understand that some of our work is service provision, but some of it is working in the system to make those necessary changes. I heard Claire sharing earlier the functions of public health, and they do remain unchanged. You know, we protect, we prevent, and we promote. So in this setting, I'm thinking about vulnerable populations is who we are really being mandated to protect in this situation. And I'd say personally, I don't think that we've done as good a job of that as we could or we should. And I think the pandemic was an opportunity for us to see that glaring miss, and hopefully in many settings public health did try and reach out to shelters and provide a little bit more support, and perhaps that wasn't boots on the ground, but certainly trying to understand the policies and the other levers that we can pull to make changes for people. And so in the province of British Columbia, definitely different context. We've just had our 2022 data from our toxic drug crisis, and the numbers are higher in 2022. Not as high as 2021, but they're just terribly shocking that 6 people a day are dying in the province of British Columbia from a toxic drug supply. So when I think about what are the ways that public health needs to be more proactive about our engagement with vulnerable populations in all settings, and so shelters are one setting. We also have supportive housing or complex care housing. We also have individuals who are transitioning from different settings, and so whether they're new to Canada and haven't figured out, and we haven't supported them to get their feet on the ground, or people that are transitioning from foster care into adulthood, that's a very challenging time for folks. And those that are transitioning from corrections into society again. We know that those transitions are one of the most critical points that lead to homelessness and houselessness and becoming unsheltered, and preventing that is incredibly important. And so I think there's a huge role for public health in our partnerships with shelter providers or other people working with vulnerable populations to understand the drivers of houselessness and what is doing that. Some of them are structural. We've heard of that today. We know that racism, discrimination are incredible barriers to people accessing appropriate housing. I know in my community, there's definitely discrimination. People will not rent to different people for whatever reason, and we know that. What's a policy lever that we can put in place to disarm that, and we level the playing field for people to access housing? We know that there's personal characteristics, so domestic violence and turmoil in people's lives. You know, youth become homeless because there's interactions, negative interactions with their family members, or you know, when they start exploring their gender identity and really exploring themselves, at times they can be discriminated against by their very own loving family, and that leads to homelessness as well. I think we know that our LGBT and questioning youth are often not supported as well as they should. I think there's also great opportunities to either, we talked about screening and testing, but really connection to care. We know that people are, I wouldn't say a captive audience, but it's people who have engaged with the service. And we've got a bridge being built in trust to bring down that trust barrier. What are the opportunities to work together and not in a sense of offloading? Because I did hear that today, you know, that public health might be asking a bit too much from shelters, and how do we work together in a better partnered manner? And I think our experience is much like you had mentioned, Tessa, that public health is there intermittently, but we don't have someone there all the time.
Fair enough, yeah, us neither.
Right? And so I was wondering, maybe would it be appropriate for when we're planning for shelters that we put an LPN on staff or something, just to have a health person on staff for your teams. Now, of course, that's another expense. Somebody might say, well, maybe that should be in the health system. Oh, don't do that, because I'll want to control it. You guys, I think it's better that they're with you, and then we can work together. But these are just some ideas that I've thought of when I think about what public health means in that policy space. Sure, there's service delivery, but certainly trying to understand the underlying drivers of houselessness and what makes people become unstably housed, or even, I'm going to say the financialization of the housing market in Canada has really undermined our ability to support people to access housing. The housing market is just completely exploded. It's incredibly expensive. Many people in this room can't afford to buy a home. How can we expect people that don't have ways and means to become housed? And so, again, how do we infuse the systems that we live and work in with compassion and love and make space for people that have less? And I think that that's got something to do with our values and perhaps who we elect, right? Who we put into seats of power. And I think that that's something that we all have to think really hard about. So,
we're currently losing more affordable housing than we're building. And also in the National Housing Strategy, the definition of affordable is 70% of median income in that neighborhood. So we're also paying to build affordable housing that rents at $2,000 a month. So I think there's the struggle of the units that we're losing versus the units that we're building, but also some of the units that we're claiming are affordable are not affordable. Or affordable to whom? I think is more of the question. And so if we look at when we eliminated the strategy around having a certain housing supply, so I was going to say, we normally talk about it as the commodification of housing. So it used to be that a government would claim that its responsibility was to house its citizens. And we saw that disappear in the early 90s. And slowly, I think, hopefully, maybe in Winnipeg, it might be about to come back because the mayor is talking about recognizing that there's not enough housing for everybody who needs it in Winnipeg. But he's also the mayor and not the premier. And so I know that she and him are looking at working closely on homelessness and that there's going to be real hopeful announcements hopefully coming out. They've talked a long time about a homelessness strategy, and I really hope a piece of that is that housing supply. Because we talk a lot at Siloam that for every pathway into, which is what you're talking about, for every pathway into homelessness, we need to build a pathway out. But we can't build the pathway out and do the prevention work. So we also need the policy stuff you're talking about and that other piece around the prevention work. A big piece, we just had a meeting, 45 of us, Jamil was there, from the sector with the mayor, and why not make it a bylaw that you have to, as a landlord, call a housing loss prevention officer that's on with the city before you evict. Like, figure out why the eviction, because so often we get the phone call 2 days too late. But when we get the phone call 5 days ahead of the eviction, hey, I got an eviction notice, I don't know what to do, we can prevent 98% of those evictions. But we can't do that if we find out about it the day after. So what are the prevention perspectives and pieces, and that's one that we are working on, but that we can be a part of in terms of reducing the amount of people experiencing homelessness, because that's such a heavy trauma that the first time it happens, right, is so traumatic that that's part of what further entrenches people in that experience. And so that's another big piece that the research and Ian de Jong talks about is like, how do we get ahead of that first experience? How do we divert from shelter? How do we build your, whatever it looks like, so you have somewhere else to go that maybe is a shelter that just doesn't feel like one and feels more like an opportunity to be supported and held in care as opposed to sharing a room with 134 snoring men.
Thank you very much. Maureen, I'll turn the next question to you and again return to the review that you've conducted. What are some promising practices or things that you identified in your review that can be leveraged or amplified to serve some of the gaps that we're talking about?
Well, one of the things I'd like to come back that you started with, Tessa, is about foot care not being in there, and then the last comment around diverting from shelters. So, reviews predominantly are going to take the perspective of the people doing the reviews. So I think this is a question coming up, but I'll answer it now. Around what was within scope, what we made decisions of on how to cast the net of what would be included. And so we took this perspective of, from a public health perspective, partnering with shelters, what does the evidence look like? And we made decisions, we used the word, we said we defined public health broadly, and what we meant by that is if it looked like and sounded like something relevant to population and public health, no matter who was doing it, what the title of the person was that was doing a certain activity, then we included that in the review. Foot care generally wouldn't fall under public health, although you've really laid out nicely for me why it should, but that's why I didn't see any studies in there. And I, even with the last comment around preventing an eviction to prevent homelessness, I mean, maybe that's something that, because public health is always evolving, and maybe in certain parts of the country, public health is already there. I would say in Ontario, probably not so much. That would be something you would see in the ministry guidelines of what constitutes public health practice. But those are some answers. But this would just be one review, and an alternate review could be done from the perspective of shelters and who they partner with, and you'd probably see, it would be an opportunity to see, are there any studies on that have been written up? Sorry, the main question you asked in terms of what did we find? Yeah. So it seemed, and I started to go here already, was around multiple collaborations with a wide variety of relevant sectors and organizations that are coming together, driven by the needs of those that are experiencing homelessness as being part of the group that's included, tended to last longer, be more sustainable, and although we weren't assessing effectiveness or impact, looked like there might be some promise there in terms of achieving goals, as opposed to what we did see more often than not. And I am a public health person. Was a public health nurse at the beginning of my career. And I've always said that what I learned as a public health nurse right out of nursing school, going into people's homes to work collaboratively with them, is what has allowed me to be the academic and researcher and knowledge translation person that I am, because it's meeting people where they're at and working on their goals, not what's in my mind about what you should be doing. But that approach of working collaboratively really came out in the literature, and that this is my opinion, too often we saw in studies where public health was going in with what they believed or what they wanted to work on, and that's what the reason for the partnership with the shelter was. They wanted to come in to recruit participants for a study or for a project, or they wanted to come in to do immunization. So coming from that field of public health, it's, that, I think you said it, Sandra, humility, we've heard that today, really understanding that collaborative piece and meeting people where they are at, meeting sectors where they are at, and then developing a common goal, I would say probably sums up the majority of the key findings.
Thank you very much. And with that, of coming and meeting people where they need, I will turn the next question to Sandra and ask about a bit about models of services and programs that public health can collaborate with and participate with shelters moving forward.
Thank you. There's a lot of really excellent groundwork that's been done. Claire referred to something that was old before, primary health care, but I'm going to go to something that's old as well. The Ottawa Charter, I think, provides a really excellent starting point for just within public health to kind of gather their thoughts and really come up with a solid plan. So strengthening community action is one of the pillars of the Ottawa Charter. And we know that we need investments. We need to set expectations with our communities regarding the availability of what should be affordable at the most basic level, not to the general population. Developing personal skills. I think we all know stories about individuals who have hit the housing and they've landed there, but then not been successful for a number of reasons. And so really trying to understand that it's not just landing someone inside a place with a door, it's providing them with the skills and the knowledge and understanding to become part of the community that lives there, and a constructive part. Creating supportive environments. That kind of situation I just described, dropping someone in there, is not a supportive environment at all. In fact, many people that I've discussed the issue of houselessness or being unsheltered, they choose to be with their family in the street rather,
All the time.
They would rather, because that's the supportive environment they need. So how do we enable that? In fact, I know of many situations where they become housed and then they bring their supportive environment into them and they lose their housing. So we don't have that right. Reorienting health services. I heard in-shelter clinics. I know that in my region, in a couple of communities, we do have shelter clinics. And our addictions physician goes there, and they have 30 people lined up to be seen. And they're doing wound care, they're providing them their OAT, they're giving them prescribed safer supply. In British Columbia, we have both of those things. We know that people that get OAT and prescribed safer supply are 4 times less likely to have a fatal overdose. So when we provide these tools to people, they're successful. If we don't, they have acquired brain injuries multiple times. We know that we need to build healthy public policy and enable, mediate, and advocate. That's exactly what our Ottawa Charter tells us to do. But we're never going to get there unless we absolutely agree that these prerequisites for health are human rights, that we need to ensure that people have peace and shelter and social justice and equity, right? That was what I learned when I first started in public health, and I don't think anybody else took that lesson, I think, or maybe some of us did. But there's a lot of gaps in the actual implementation of these policies. So I guess one piece that I next want to talk about is in British Columbia, we have decriminalization of small amounts of some substances. But I don't think that we've ever considered decriminalizing being homeless, because in fact, we treat people who are unsheltered as criminals in many situations. They're just trying to get by, and we will ticket them, and we will move them off, and we will just, in Nanaimo, where I live, eschew them out into the farthest reaches where we don't see them in our beautiful downtown. And that, to me, just absolutely just breaks my heart, because I'm confident to decriminalize something that is, a substance that's killing people, but homelessness equally is killing people, and we've not figured that out yet. So I don't know if I answered your question.
Thanks for that, Sandra. Tessa, I'll return to you and ask you if this conversation is for you more about sets of services and holistic approaches or something different. And how do you see the interaction with public health and considerations when working with shelters?
Yeah, I think one of the things that this conversation for me is about recognizing access. And so we talk a lot about, like, we have AA in the shelter, we have NA in the shelter, we bring all of those things in because it's the only way people will go to them. And to your point, that people leave housing, like, we have people who leave housing and come back to the shelter because that housing was lonely, or because they've been incarcerated their whole life and not being on someone else's schedule is really uncomfortable, or whatever. And so I think part of the conversation is recognizing that there's a population that can't have the right access to the healthcare that they need and to the public health care that they need and the interventions and the supports because of their experience of houselessness and whatever brought them to that experience of houselessness. And so I think, at Siloam, we have, for example, a 20-unit residence for people that were experiencing homelessness and addiction and went to rehabilitation and are now sober, but would have left the recovery center after 30 days back into homelessness. So we have 20 units to kind of try to see those people through for up to 18 months. That's our transitional housing. But we also have 85 units of long-term supportive housing, and that's age in place. So over 50% of that building receives home care, is seniors. That age is a little lower with people who've experienced chronic houselessness. But one of the things that's really interesting is we have successfully partnered with Main Street Project to move folks from encampment right into that building called the Madison. And that's because they show up, and normally they already know someone from a previous life on the street. Hopefully that's a good thing. And often it is. And they find no judgment. And they find an instant sort of community of people who have similar life experiences and similar stories. And so I think one of the things that when we're talking about that ability, you talked about trust, like that warm handoff, or that capacity to have somebody see somebody and feel like they can access care. The intimidation factor of going to a doctor or going to a hospital when you have sort of systemically felt like you didn't belong everywhere you went. And that's, I think, the core of what shelter and outreach centers and drop-in supports can offer, is that sense of like, at minimum, you belong here. And we are going to see you and love you and offer you dignity. But we know of people experiencing homelessness or houselessness going to emergency and getting ignored, sometimes fatally. We know of people who experience racialization going for healthcare and having a terrible experience. We know that those systems also have memories attached for residential school survivors or 60 Scoop survivors. Like, we know that trans folks have had really gender non-affirming conversations with medical professionals. If we can treat them in a space where we say, we've built this relationship, and we've built this relationship, so this is a triangle in which you can feel safe to access that care. And so as much as it's whatever the partnership looks like and whatever the piece of the puzzle is, it's that ability to bridge trust that I think is really key about when we offer this care where the people are at.
Thanks. Thank you very much for that. Maureen, I'll turn again to you and ask you a bit about, so you explained the review, and what would be some other areas, if you had to reframe the review, how would you go about talking about some of the things that Tessa mentioned about houselessness prevention and other things? Would there be a space for that? And what would be some of the research priorities that you identified from the literature and from our conversation here?
Sure. So a good place to start was the scoping review, to just understand what's there. But I think a more multidisciplinary team that could have, and so likely not rapid, it didn't need to be rapid, we had time. So this was likely not something to answer in a rapid way. A multidisciplinary team to bring different perspectives would have been great, to have had both of you as part of the group we were developing the research questions with, to make sure that we discussed and debated public health and things like that, to make sure we got a more fulsome view of the literature, or multiple reviews that then could be brought together on a particular topic. So that's one area. Something else that from this conversation that strikes me as important to talk about is what we learn from what doesn't go well. So my daughter's 20, and I've said to her most of her life, you're going to learn the most from the things you fail at than everything that just comes easy to you. And I think the same applies here. So we fear that it's likely failed partnerships will never get written up that can be accessed and lessons learned from. But I strongly encourage all of you that to find ways to write things or provide them in a way that these learnings can be passed on to others, of the things that we can be better at, or that didn't go as planned. So that's something I think is really important in terms of next steps, is we need to learn a lot more about that. And I wanted to come back to a more personal story about the Ottawa Charter. So, I went to McMaster University, 4 years of nursing. I went to work in public health. I definitely heard of the Ottawa Charter, but after 3 years of working in public health, I went to go live in Australia for a year. And I was like a superstar there because I must know all about the Ottawa Charter because I'm Canadian. And I was really embarrassed. I did not know much about the Ottawa Charter and said, I better go find out what the Ottawa Charter is. They're all talking about it down here. And so that is a problem with the system. I'd heard it, but didn't learn enough about it to really know how it was being applied in my practice as a public health nurse. And everyone working in public health should know how that's being applied or not, but be clear about that. So those are a few of the things, other things to start thinking about is ethical ways of doing particularly evaluation research. So how do we do rigorous research knowing that randomized controlled trials, I'm quite sure, do not belong at all in this area, but then how will we get policymakers and others to take the evidence seriously if still others in the quantitative world would say you have a lot of uncertainty in these findings because you haven't used the most rigorous research. So really thinking from a multidisciplinary perspective, how do we do the as rigorous research as possible to evaluate and assess impact, but is not harmful to the participants in those studies, both those who work in shelters and those who would be involved in accessing those services.
So I'd just like to speak to that, Yoav, because I honestly think what you had said before about the amputation is exactly where we need to go. Money talks, and I don't think that people understand the cost of our inaction, our lack of action, our lack of political will in the realm of being unsheltered. There's prevention that can happen rapidly. I know when we've done our point-in-time count in Nanaimo, the number of people who are chronically homeless is actually not huge. There's a cycle of homelessness that happens. And people, once they've experienced it once, it feels like it's almost like a risk factor for experiencing homelessness again. And so if we could really get a little bit upstream again, hey, public health, wow, and prevent this from happening, I think that all of us in this room are really experiencing the symptoms of failed social policy, right? There's not enough housing, people are in shelters. The income is not adequate for people to make ends meet, and they're falling through the cracks. And so public health is experiencing, and shelters are experiencing it. And I wonder, where is the lever we have to pull? And so is it at the elected official level? Is it at the staff level in our municipalities? Because those are two different levels, let's be clear. There's the elected officials, and then there's the people that get the work done. Who do you need to work with to actually make the changes and have them stick? Is it through not-for-profit? Is it national? Is it shame-based? Is it human rights? Like, I'm not sure the lever to pull, but there's a few out there.
I think one of the things that's really interesting about what you were just talking about in terms of the control and not wanting to do harm, and I think I don't know, so my husband and I always use the term draft thought when we're like, I'm not sure if what's about to come in my mouth is a good idea. So draft thought. But I feel like there's so much harm in not moving forward that like a randomized control of one shelter to one shelter, like that, all of our funding is grant-based. Like we get grants to do wild stuff for like 6 months. So even if it was like, we're gonna do a 12-month intervention of what does it look like if we have paid foot care and all of the people at this shelter who have diabetes won't get it for the first 12, like whatever that looks like, the people unfortunately experiencing houselessness are already experiencing an inequity of services based on their jurisdiction, whether they're rural, whether they're northern. So it's already randomized. And doing something in that area to say, how could we prove that this increases outcomes, one shelter versus the other, would be harm reduction for everybody at the one shelter you decide to work with, and potentially help change policy for the future. So I think what, from the perspective of, I remember we got a grant for a while so we could do support for youth aging out of care. Then the grant was gone. Now we just fund it out of our own budget. We got a grant for a while so that we could do random other thing. Now we don't have that. We actually couldn't fund it out of our budget. It doesn't exist anymore. So there's a lot of, and I think that's part of the challenge when this isn't built into a system of clear funding and clear responsibility and clear prevention, that it's pop-up. So yeah, we have a great program for 6 months, but then it's gone, and it only touched those people in that 6 months. But if that was done and there was research attached to it, as opposed to like a 3-page, very well-written grant report, if that could feed into something that could advocate for that further, except for like on my next grant proposal, like that would be fascinating.
Yeah, so it's the land of pilot studies that don't have continuity, and economic studies of prevention of houselessness are definitely lacking, missing here. I will return to Sandra and ask a bit more specific into the weeds question about oral health and how you some opportunities and some ways of integrating that into public health and into work with people who use shelters.
Very interesting topic. Dental care in public health is an interesting space. So we certainly invest upstream in prevention, and we do early childhood things like dental screening in kindergarten, checking for decayed, missing, and filled teeth, just to understand how the dental care of the population is, and then we stop. Maybe there's some dental hygienists working in public health that do work with either some more marginalized populations, perhaps that are going into facilities and getting some specialized care. But just like the rest of the parts of the head, Yoav, that's not part of the healthcare system. We don't care psychology, we don't pay for glasses, we're not going to pay for dental. So I'm very curious if, as we go through, when do we decide that, if we're going to have a national dental strategy, right? That's needs-based, I think, or they'll have some sort of means testing. I think that at some point in time, as a society, we'll have to decide that some of these services are a right that people should get and not be charged for them. They should just be, access them based on their means. And so that would include glasses. I'm sure that there's a ton of people who are unsheltered that need a new glasses prescription. It's very hard to take care of glasses. I can tell you mine are very dirty right now, and I'm a mess. And I'm very well organized. Dental care, hearing, right? Hearing, any of the other senses, right? Hearing aids. I know of a gentleman that I work with, and he is the loudest guy and very scary. He's about 6'6", and he shouts, and he's so scary. He scares everybody. And then someone said he's deaf. So if he had a hearing aid, his interactions with people would be different. It is just so fascinating. He's very afraid. He's scary. He's a scary, scary man. But then when I talked to him and I figured out he needed hearing aids, I was like, holy smokes, how do we get this? How do we access these things? And so when I think about dental care, it's part of the whole package of things that we are just not providing to people. And I mean, there's many other sectors of society. Seniors need this as well, right? One thing we haven't touched on is education. And for people who are, whether they have an acute or acquired brain injury, people who experience a toxic drug poisoning and receive naloxone, they have a state of low oxygen in their brain. They have hypoxic injury. Anoxic brain injury can happen if it's prolonged. These are repeated over time, and we know that this is going to be an incredible challenge. We have not, in British Columbia, figured out how to measure this. But we know individuals some folks, without even a brain injury, they have low literacy level. And so even the things that I do in public health, I'm like, here's a paper, read it. Oh, okay, well, I checked, it's grade 5, you should be able to read it, right? That's not the case, and there's a lot of assumptions, and there's a lot of, let's say, expectations I have of a basic person's ability to function that I think we need to understand that these folks are extremely vulnerable, and we need to walk alongside them with a really bright light and guide that way to them, to the path. Unfortunately, we don't have processes to do that right now, and I think we need to build them.
Yeah, with what Tessa said about traumatic brain injury, that is also one thing to think about in terms of level of education and to walk alongside with someone who cannot.
And I think on the glasses thing, just because it's interesting, like first of all, if you need to donate glasses, we'll take them at Siloam. We also take hearing aids. But so many people who are trying to get housed, if they've had an experience of losing their glasses, may be perceived as not literate, but it's actually that they can't see. And so you're hoping that they're going to do, and we have caseworkers, but obviously not enough for all of the people in the shelter. We'd have less people in the shelter. We wanting to do their paperwork with them, and they don't want to admit that they can't see, and lots of folks don't want to admit if they can't read, but we don't often know which one it is. And so when we have an optometrist in, and we have lots of reading glasses, and prescription glasses that people donate to us anytime, and it's great, but one of the challenges is until the optometrist comes in, we assume sometimes wrongly a lack of literacy. And then the person sees the optometrist, and the next time we are meeting with them, all of a sudden they're like, oh, all of my forms are done, and I found these extra 5 online, and I did those too. And we're like, what just happened? Oh, I got glasses. And so you can get glasses, I think, every 2 years with EIA. But if you're experiencing houselessness, and you get beat up after the bars close because people think it's fun, or you are near somebody who's having a lot of feelings in a moment, and you leave behind your glasses. Like, whatever happens, there just isn't, so we're often replacing people's glasses because they've done their allotment. And same with dental care. They've used their allotment, and their allotment was the equivalent of pulling one tooth with pliers with no anesthetic. And so it's like, okay, well, they need a root canal. That's not going to work. And so we're filling those gaps, but right now just in a volunteer capacity.
So I'll continue with you, Tessa, and ask you about some of the services that you provide officially and unofficially. What other things, what other training and public health could do to support your staff in terms of work, actual staffing, but also training?
Yeah, so I think, we have a health clinic at Siloam, and we're really blessed to do that. And there's a ton of services. It's all by volunteer. So the professional comes in and volunteer. We have a dental assistant on our team because we wanted the dental hygienist and the dentist's time to be really well used. And so our donors make that possible. But she runs the whole clinic. So in that clinic, we have chiropractors and physiotherapists and massage therapists, an optometrist, a gynecologist, an ophthalmologist, 2 primary care doctors, wound care and foot care. But all of that right now is just because people are donating the 2 hours they have, or the 4 hours they have, or our doctors are pretty awesome and do close to a full shift a week. Then with public health, we do STBBI testing, we do pregnancy and STD testing. There's like tons of supports that way, and lots of support around immunization. I think one of the thing I laughed at your neck up comment, because we'd really love to see more support around mental health and trauma and EMDR. My team asks me to try to figure out how to fund EMDR in our space all of the time. To really help people through whatever trauma's led to that experience of houselessness, and then hopefully can help with the right supports lead them out of it. So I think for our staff, there's 2 pieces. One is the need for training around, and we're starting to do this, but it kind of doesn't super exist. How do I positively affirm somebody with an acquired brain injury's behaviors when they're in line with expectations? And how do I hold rules while holding that person in care when they can't understand the rule because of what's going on? And that balancing act between what is somebody's capacity And what do we need to do to keep 200 people safe while they're eating a lunch? And so that, I think the hardest thing for our team to do is to say, you need to take a break because you just did something that is not tolerable, to keep this space safe, to keep this space respectful, and to be focused on meeting everybody's needs. That's really hard when there's 200 people in a room. It's a lot of needs, right? And so that balancing act and so we're moving to behavior-based entry at Siloam, and are doing, had somebody do a rapid review of the literature and is supporting us in developing that code of conduct and how we move forward. And that's really exciting because it will help us have some of this structure. But there's populations within the houselessness, larger population, where it's like, what do those specific supports look like? And how do we start to carve those out on our end? And very gratefully would love to be mirrored on the prevention end.
Thank you very much. I'll turn the last question to all three of you to tell us a bit what we didn't ask and what we didn't talk in this panel, and what do you think are some important points for us to consider for our conversation in the next day and a half of our time together. What other opportunities for conversation do you envisage? I'll start with Maureen.
Well, one of the things I wrote down as well during this conversation, and I feel like I've been beating up on public health a bit, and public health is my family. It's been a part of my entire career. And Claire talked about this morning, or this afternoon, in terms of, I don't think there's really ever been much of a time that I can recall in the last 30 plus years where public health isn't under threat of losing funding. And whether or not that's because there isn't the data to prove that what they're doing is making a difference. And I have to say, quite honestly, that doesn't seem to have gotten better since I was a public health nurse in 1989 in terms of being able to have the data. And I was really hopeful at the beginning months of COVID that this would mobilize the community, the public health community, to get together across the country to find better ways to measure what they do. And it's not happened, and we're 3 years later. So public health is always under threat. We know this time 3 years ago, in several provinces across the country, huge cuts were coming, and structural changes that have only really been put on hold and are now starting to go forward. And at the same time that these reductions are happening, or threat of reductions, public health is also new things are being added in terms of what they could or should be doing. And so they are incredibly stretched. I don't know if it's equivalent to other sectors, but extremely stretched, and one that can only do so much. And so it's trying to think about how do we get to a point where the issues we've talked about tonight are valued enough by, you said it, Sandra, the people that are voting and putting people in power, because that's why in Ontario we're now moving to privately go get your knees done or your hips done, because enough people are complaining about that. So a lot of the issues we're talking about don't make those agendas because the people that are voting and putting people in power are different, right? Aren't bringing those issues. And so I really think that we need to, how do we mobilize Canadians to value health for all and not just for some? And in a way, I feel public health is stuck in the middle of ever-changing, more and more things to do with fewer resources. And moving forward, I mean, you would know this from a communicable disease. I mean, communicable disease was pre-COVID 40% maybe of what a health unit had funding to do. It's now going to probably be 60-ish%. So, and everything else needs to fit with less money and more things being added. So we definitely have a challenge. And with the education piece, our public health, those that find themselves working in public health, what training are they getting prior to arriving in public health to prepare them for these new challenges that they are being asked to deal with? And so we have a lot to change there and understand with respect to that.
Thanks for that, Maureen. Sandra?
I think one thing that just popped out from the rapid review was the predominance of communicable diseases. I think that was really, really obvious. Part of that was because we asked about public health, so you explained that in that review. There's a lot of other aspects of public health that could have come up. And the reason why I think the communicable disease came up is because it's a regulated function, right? And so there are certain regulated functions that are by law prescribed and have to happen. And so follow-up of communicable disease is one. You mentioned a really neat twist to this idea about a bylaw or some sort of even a provincial law. Hey, why aim high? We do have laws and regulations and those levers. And I want to say Manitoba has some things that are better than elsewhere in the country. So we have a housing standard here. That does not exist in British Columbia. So the houses here must have certain attributes, and I cannot enforce that in British Columbia. In fact, the housing quality can be much less good. Poorer, I guess, is the word I want. And so when I see that you did the review and it just comes up as that, I'm thinking, what are the legal frameworks that we need to apply to equity and social justice? And if there's a legal framework that could be applied, maybe methods and tools could figure that out, I don't know. But if there were ways to move a system, I think that the regulatory functions might be the way to get there. And if there were just even some basic things that we could see from other countries, maybe there's a review we could do on that. And then we could start working with our political leaders to say, hey, listen, you know what? This is harming everybody in our community. Dr. William Osei, one of my favorite public health doctors that I got to work with in northern British Columbia, he would say, in the race of equity, you aren't finished until the very last person is across the finish line. And a community is only as healthy as their least healthy person. So any community that looks around and looks at me, look at us, we're great. We're actually not doing the appropriate assessment, and we're not actually caring for your community. It's very, it's a blind view, and it's, I would say, quite ignorant, and it's very privileged. And so as a society, I think we need to open our eyes, take the blinders off, and start looking at if there is legal tools we need to apply, and it might be housing standards in some situations, and it might be in the province of British Columbia, we have housing needs reports. I'm very curious about setting some benchmarks for a population size of this. How many shelter beds must you have? If you have a 40% poverty rate in your community, 40% of the available housing should be at an affordable rate. And you should not be allowed to develop any further housing in the community until you have the benchmarks set for all of the needs that are there. And if people want to have these really huge mansions that are built, it comes with an incredible cost and a delay that will take them into the next millennium because we have other priorities to build in our community. So anyways, just some really aspirational goals about how to get there through legal frameworks.
Thank you very much. Tessa?
You're a hard act to follow. I like it. I think one of the things that when we think about people experiencing homelessness, that I hope you sort of take with you into the next couple days, is we have people who, we have 3 social enterprises at Siloam Mission that employ people that are staying in our shelter, or who've recently moved out of our shelter and into housing. And some of it's very pathway to full-time employment. So that would be, we have a commercial laundry program, we have a dish pit program. But one of it, the sort of first one, is just street cleanup. And it's kind of, they're on the team, they get the training, but it's very flexible. And when we ask that population what they're spending their money on, it's presents for their grandkids. It's postage to connect with family wherever family is. It's often a pack of extra cigarettes, obviously. and things like that. But all of these people, when you talk about people experiencing houselessness, I hope you have an opportunity to build a relationship with somebody who's houseless, so that when you think about it, you see that face. And you see that person that for me and for Siloam as a Christian organization was created in the image of the divine and is so worthy of love and affection and connection to a community of care and support, that they are not faceless and that they are not nameless to you. Because I think that's the biggest challenge, is that when we talk about houselessness and we talk about homelessness, we're talking about an aggregate group of people that we don't understand. But if you can get to understand them and know that remembering their birthday is going to light them up and they're going to talk about it for 7 weeks, or know that they would really like you to read the Sunday paper so that they can tell you about it because they read it every Sunday, it makes them feel very smart to talk about it, or to know that they're getting sober to reunite with their kid because they were apprehended at birth and they don't want their kid to feel the way that they feel about being abandoned. When you know that person, when you love that person, your policy choices and your advocacy change.
That was a big one.
Wow. Okay. We have lots of things to take from this conversation into the next day and a half. Lots of amazing thoughts and ideas and gaps that we need to address. I want to thank Maureen, Sandra, and Tessa for a fantastic, scintillating conversation. I'll think about it. I'll think about Maureen's suggestion to write all my failures, but I'm wishing everyone a good evening. And any other messages that I need to convey other than the session tomorrow is starts with breakfast at 8 here, and we will start at 9 with the activities. Thanks.
Love that.